Welcome all of you to this live program in Orthopedic Principles. Today our guest of honor is Dr. Mahdi Siala from Nice, France. Dr. Siala completed his medical education in Paris, France, following which he joined orthopedic residency in Toulouse, southwest of France, and later subspecialized in upper limb surgery. Subsequently, he completed a fellowship in hand surgery with Dr. Marc Alias. He worked as senior consultant in traumatology and upper limb surgery in the surroundings of Toulouse, in southwest France from 2019 to 2022, before moving to Nice in 2023. He holds a diploma from the European Board of Hand Surgery and has several publications in his chosen field of upper limb surgery. If you've noticed, Dr. Mahdi Siala has delivered a couple of lectures in our channel and so reached a huge audience. And today is my great honor to bring back Dr. Mahdi Siala for this wonderful live program. Over to you, Mahdi.
Okay, thank you, Tesh. It's actually my pleasure to be here for the third time. And today we are going to speak about the Lacertus Syndrome, which is a quite hot topic in upper limb and especially neurosurgery nowadays. And I'm going to swear an oath to speak the truth, the whole truth, and nothing but the truth on this lecture. As a for starters, I'm going to tell you about my own experience with Lacertus fibrosis. It started a few years ago when I started getting interest in ultrasound surgery. And Lacertus was on one of the diagnoses that were introduced to me at that same time. And I was very keen about it. And, you only see what you seek. And I started diagnosing Lacertus and getting people getting better with surgery. And that's what made my interest in this topic. So I have a small conflict of interest as I consulted for Kerry Medical, and they're releasing a knife to cut the Lacertus and carpal tunnel and also the trigger fingers. I also have a conflict of knowledge as I would like to thank all of the people that helped me gain knowledge, and especially Donald that you all recognize for introducing Wallen to us, and Elizabeth for her work on the Lacertus. There are so many other friends that I'm going to talk about during the talk: Olivier Marès, Thomas Appart, Vincent Martinel, but they're coming in the way. And of course, Amir Adam Ahmed, that I had the chance to meet finally this summer at the last FESH Congress. They had all done an amazing work on the Lacertus syndrome the last few years. As you can see, last publication are from last year, and we're going to talk about some very hot publication. So if you have a look at PubMed, the first reference to the word Lacertus dates back to 1957. Truth is that the first description has been done a few years before that in 1951, but the word Lacertus was not used at that time. There is 96 results only in a period that's almost 50 years, 70 years again, and you see that most of those publications were made in the last 15 to 20 years. All of the publications that are in between are related especially to the Lacertus fibrosis as a need to reinsert biceps tendon and nothing to see with nerve compression at the elbow. So I'm trying to give an honest interpretation of what is belief versus what is science, and starting to cite this article from the team of David Ring that a small number of surgeons, and this concerns the US, but I guess we can extend that to the whole world, a small number of surgeons perform the large majority of uncommon nerve compression procedure. This was published this year, and I think that this is owed to what I said earlier. You only find what you seek. And if you don't try to make the diagnosis, and if you're not aware about those kind of really uncommon nerve compression, you cannot find them. And this is what happened to me at first, and I'm going to come back to that later. So, small word of anatomy: Lacertus in Latin means lizard. And as you can see in this small image, actually the biceps tendon has a fascia that lies over the muscles and go to the underneath of the skin. And it was believed to have the form of a lizard's tail. That's why they call that part anatomically the lacertus. It lies over the brachial artery and the median nerve. And this is human specimen that you can see. And this part is the Lacertus fibrosis. A study last year, an anatomical study on specimens, found that there are mainly three types of insertion of the biceps. The most frequent one being the normal type that we all learned, with one tendon inserting on the radial tuberosity. However, few variation can occur for 30 to 40% of the population. The second most common type is two bands inserting on the same radial tuberosity. And the third type is the three bands type that inserts on the radial tuberosity. The thing is that with type 3, the article that was published and that is cited on the slide said that they are prone to have no Lacertus fibrosis, which can be useful in further imaging, because having an idea about the type of Lacertus fibrosis, of insertion of the biceps, can give us an idea about the presence of Lacertus fibrosis or not, even though those types are around 10% of the population that was studied in this article. It is more common than previously thought. Tang in 2021 bring the light again on the syndrome, and stating that we really have to consider that syndrome versus the superficialis pronator syndrome, because he was stating that pronator syndrome is also a word that we use quite widely, and we have to be more specific on the kind of neurological impression. I would like to thank Vincent Martinet, that worked a lot on upper limb surgery and ultrasonography teaching, and whom I share the patient for ultrasound and Lacertus fibrosis with. And he made some amazing drawings about this in cartoons that you can find in French, English, and many other languages. And actually, he did pretty nice views of ultrasound. And I'm coming back to this point where ultrasound is and can be helpful for the diagnosis and the treatment of Lacertus fibrosis. He's also working on a book that he's releasing quite soon. I don't know exactly when, but I wish him all the luck with that book. So going back to the Lacertus, this is how the patient history goes. Usually you can make the diagnosis almost in 99% of the cases just by the diagnosis, by the history of your patient. They complain mostly of hand strength loss, hand endurance, or fatigue loss. And this can involve pronation for more than 5 hours a day, as Elizabeth stated in 2013. It also can be a misdiagnosed carpal tunnel syndrome. The GP sends you the patient, it's carpal tunnel syndrome. The EMG says carpal tunnel syndrome. And when you examine the patient, actually, it's more even a double crush or just an isolated Lacertus. So clinical examination is made over the Lacertus fibrosis, and starts in my hand with the scratch collapse test as described by Susan McKinnon. Like she said, motor testing of all upper limb muscles, and like all neurological surgeon involved in neurologic surgery should do, we have to test all of the upper limb muscles. So it is very important to find that small, this should do it. It is very important to diagnose all of the muscle with strength loss, and all of the muscle involved in the compression neuropathy. Usually in the Lacertus fibrosis, it's the key and tip pinch, the flexor carpio-radialis is involved, but I think in my mind more difficult to test than the flexor pollicis longus or the flexor digitorum profundus on the index finger. You usually can test it with, like we saw on the last presentation I gave on the channel, by testing the external rotators of the shoulder. But in case of elderly people or people that have issues understanding or with a large rotator cuff, you can also test this by doing a testing of the hip abductors. You scratch the nerve over the Lacertus fibrosis, and then you try to push against the feet of your patient, trying to abduct them. And you just have to ask them to make the feet not touch each other. And the last sign that I would recommend is to touch actually your patient and to try to compress the nerve over the proximal part of the Lacertus fibrosis. And I'm insisting on the Lacertus being touched proximally. I'll come back to that part a bit later on. And the thing is that you have pain and tenderness over the site of compression. Well, your diagnosis is almost made. Technically, it's a triad that's been described, first of all, by Elizabeth Haggart, but that has been published again and again. It's the pain over the side, the weakness of the muscle test, and the scratch collapse test that's positive. I think the scratch collapse test is more of a negative predictive value because sometimes you can have a compression without the scratch collapse test. I mean, you cannot have the compression without scratch collapse test being negative. It's a very, very good value for predicting that. And you can also use the antagonist test that can be done by finger, by pressing pressing around the nerve just to change the way the nerve is going under the skin. And you can do that by taping. It has been described by Vincent in an article he published last year. Also, the Lacertus notch that was described by Jean-Paul Brutus is interesting. You can, in some cases, have a small notch on your skin due to the direct attraction of the Lacertus fibrosus. It is known to be more important and more present in people with double compression at the elbow, may it be radial and Lacertus or ulnar Lacertus. Now, do we need other exams and are they useful? Imaging, electromyography, biology maybe? Well, I think that in the Lacertus fibrosis, alas, which is part of the belief versus science debate, is that the electromyography is almost always negative, even in the hands of very good electromyographists. We think that this is due to Sunderland zero compression of the nerve. We will come back to that, but there is also a retrograde neuropathic pain channel that we are also exploring right now. So electromyography is usually negative. Ultrasound can be helpful for the diagnosis and treatment. The nerve can show many signs of compression, whether it's static, which is almost never the case, but especially dynamic. You have to taste your nerve and to look at your nerve in pronation and supination also. It is very important. I remind that pronation for more than 5 hours a day is a factor that has been found to be significant in persons with a certain disease. MRI also is a very good indicator, but I don't think that you can trust your friendly neighborhood radiologist with those. There is a nice study by Balaban and Al that states the different sizes that we have to expect in a normal Lacertus fibrosis. But this is very tricky as radiologists are not trained for that kind of examination and to give you the exact numbers. The tricks with the Lacertus fibrosis during the examination is the double crush or multiple crush syndrome. Usually, the Lacertus fibrosis is associated with the carpal tunnel syndrome, but Lacertus fibrosis can also be found in a single compression site. Superficial spinator syndrome, as we stated, the main clinical difference is that the compression is more distally painful than in the Lacertus fibrosis. It's interesting to have an ultrasound when you suspect double crush or multiple crush syndrome in a median nerve at different levels. The cubital fossa is a very interesting spot just before the Lacertus fibrosis and the carpal inlet at the pisiform for the carpal tunnel syndrome. But we already had a talk about that. Usually the difference is that people complain of pain and clumsiness. Sometimes the GP sends you the patient, the electromyogram says, okay, this is carpal tunnel syndrome. And when you examine the patient, well, abductor pollicis longus can be weak if you also have double crush syndrome, but you have to test the flexor carpi radialis, the flexor profundus of the index, and the flexor pollicis longus. It also happened to me and to some colleagues at some extent that people were referred for TMC arthritis, and the GP says, okay, you have an X-ray, and the X-ray shows TMC stage 3 or 2 arthritis. You have to do the surgery on it, or you have to do some other treatment. And actually, the patient, when you test them clinically, they don't complain of the TMC arthritis. They complain of clumsiness, they complain of pain, they complain of weakness in the hand. It's quite different on the clinical aspect. So the non-surgical treatment can consist in taping, as I said, but it's for, in my hand, more a diagnosis tool than a really treatment tool, unless for patients that really have fear of injections and everything related to surgery. Injection have been described. There was a case report by the team of Nakagawa in Japan in a baseball player that was 19 years old. And Thomas Appel also released his series of injection. This image is taken from his article, and in my hand, it's more 50-50 changes. I really keep the injection near the Lacertus. I started doing that, I think, 2 or 3 years ago. Under ultrasound, but I really keep that for my Lacertus and like really beginning Lacertus syndrome that are isolated with people not complaining of any other crush. About the crush, I also forgot to say that you have to look for the spine because cervical spine is also a site uh, of compression of the nerve that you have to get an interest on, especially with MRI. So the landmarks, where does the search fibrosis lie? Well, Elizabeth Haggard gave us a really nice tool. It's called a triangle, the Haggard triangle. So you put your middle finger on the biceps tendon, your thumb on the medial epicondyle, and you try to make an equilateral triangle. And your index finger would automatically lie on the search fibrosis. The incision to release that obviously is a little bit more proximal, and this is where we have to have a look to. So the surgical treatment can be open or under ultrasound guidance. The important thing is to release the Lacertus fibrosis. The question that remains for open surgery or ultrasound surgery, how big the incision has to be. Susan McKinnon said, and she treated also the pronator superficial syndrome at the same time, described an incision that's 5 to 6 centimeter. Elizabeth Haggard, a 2 centimeter incision, and Amir Adam Ahmed in his last article showed that it can be with a mini invasive incision if you're really acute about where the Lacertus fibrosis is. Actually, when you palpate your patient that are not that are quite thin, you can palpate the cord of the Lacertus fibrosis in very thick Lacertus. This is the set I use when I do this under a local anesthesia, and at the office, you can see the injection of the wall endpoint. It was a double crush syndrome. It has been described 2 years ago only. So as you can see, this is a very late description of those technique. And this is the setting. So this is this. I always try to always start with the carpal tunnel, and then I go to the Lacertus. So it can be done with different instrument that has been designed for to that, retrograde, antegrade, percutaneously fully or with a small incision like I used to do. And you can see that the Lacertus is not that complicated to release. It's very superficial. The median nerve and the artery are quite far from it, deeper in the layers. So what about the results now? Strength recovery has been studied. Last year, 3 articles were published by 3 different teams, one in Indonesia, one in Spain, and the last one in Turkey, and all found a better key strength, key pinch strength, and flexor immediate recovery for some of those studies in more than 90% of the patients. It was interesting to see that if you do that under Wallant, and most of the studies that studies the Lacertus are done with Wallant anesthesia, allows you to test the strength perioperatively. And it's quite funny what you can make your patient do during the surgery. They can actually help you during the surgery for that. It's also interesting to see that some of the Lacertus are the result of failed surgery of carpal tunnel syndrome. I myself had my first Lacertus that way. I published 2 weeks ago, still not published, but accepted 2 weeks ago, bilateral release of the carpal tunnel under ultrasound. When I started my ultrasound, I took my first 10 cases of bilateral compression and tried to have an idea about my results. And comparing this to at the follow-up, I had one of the patient was not very happy with one of the side, and I was wondering why one side was going well and the other one not. And actually, when I examined her and I talked about her with some of my friends and colleagues, I actually diagnosed Lacertus syndrome when I saw her 3 months after her surgery. So it was very interesting for me to get into Lacertus surgery. And actually, she was my first Lacertus that I did the surgery on few years ago. It also has been described that it can help with shoulder pain. Vincent worked on it a lot, and he published an article where the pain was ameliorated after the surgery of the shoulder that did not allow pain recovery, but just range of motion in a patient with a calcification of his rotator cuff tendon. It's quite impressive what Lacertus can be involved on in this concept of retrograde neuropathic pain. Complication with Lacertus surgery. Well, all of the branches, superficial veins, and bleeding area, it's a richly venous area where you can, especially if you do it percutaneously, injure some veins, and this leading to a hematoma that might be impressive in some cases. We exchange picture with some colleagues, and the hematoma can be very impressive. It's not that painful, but it's since we're directly under the skin, the hematoma can migrate distally a lot and be impressive for patients. So I advise you to be cautious, especially with patients under anticoagulation and anti-aggregation. You can, like happened to me for my first case, miss multiple nerve compression or double crush syndromes. Hypertrophic scar happen mostly in patients with open release, and CRPS has also been described in some articles. So the take-home messages of this talk, that is quite a hot topic, is that the diagnosis is mainly clinical, with asking your patient the history, the past medical history, and the anamnesis correctly, orientating it on the issues and the aspects you want to focus on. You can make the diagnosis. The clinical diagnosis is just the confirmation of your suspicion after the anamnesis. Normal electric nerve conducting study and EMG is the rule, and imaging is a help, but not a rule out exam. The ultrasound is useful, as I said, for both diagnosis, but especially for the treatment. It's less effective in my hands, at least, and this is just my personal opinion, in Lacertus syndrome that are quite advanced, or multiple crash syndrome. I prefer to do the surgery, especially if the carpal tunnel it's quite evolved and severe, and it's a thorough surgical technique that you have to master before going into Lacertus. So I advise you to go see people that do that surgery quite often and to visit them. There are nowadays a lot of people around the world. You can find some in Turkey, in Malaysia, in Indonesia, sorry, and in the Gulf countries. France has a lot. So it's quite interesting to interact with experts that do that on a daily or weekly basis. And as a conclusion, I would say that Lacertus syndrome is more common than what we think. It's based on history and clinical examination, and you had the presentation that described the state of the art of this topic that I find very interesting and enriching, as we cannot trust all of the examination we have, and we have to rely on our clinical sense for treating those patients that are quite satisfied with that kind of surgery, with good results and good strength recovery and function recovery after surgery. This is the references I use for this work, are quite lately enriched. And thank you a lot for your attention and for the occasion to give this talk.
Thank you, Mahdi. Mahdi, you can stop sharing.
Okay.
Thank you, Mahdi, for this great presentation. And thanks for the new insight. Maybe let's have a few questions. One is the usefulness of the scratch collapse test, which Susan McKinnon described. Of course, you've mentioned Susan McKinnon. How often do you use the scratch collapse test for the diagnosis of Lacertus syndrome?
Well, truth is, like for carpal tunnel syndrome or any other compressive neuropathy, I use that test systematically. I mean, when I examine an upper limb, I start with the proximal part and I go distally. I test all the muscle, I test all of the suspected compression location, because the nerve can be compressed in more than 5, 6, 7 locations sometimes. So I try and attempt to test them one by one. The scratch collapse test is very sensitive as a test, and you can reproduce it. That's what's interesting, especially that you can hide that test using some cryogenic bomb, like for athletes. So it's impressive in the sense that even the patient understand that something is going on. They're not specialists. Um, they're not they're not very informed about that kind of syndromes, because even the GPs and the medical population in general, even orthopedic surgeons, are not all aware of the existence of that syndrome. So you're a magician to their eyes, because you do the scratch collapse test. 99% of the time, I do it with the external rotator. I only used uh, the hip abduction test, I think, in well, less than 2-3% of the patient I examined. And the thing is that you can always have a response. And when you don't have a response, that's when I start asking myself question. I also can make injection at that time to have it at the same time as a diagnostic and prognostic tool. But the thing is, if the scratch collapse test is negative, in my hand, I tend not to go to surgery directly and try to make my diagnosis more accurate. It's a very useful tool, and I cannot imagine my practice without it nowadays.
And maybe, yeah, so for the benefit of audience, I just want to recap. So weakness of the FCR, weakness of the FPL, and weakness of the lateral two FDPs with a positive scratch collapse over the elbow, medial elbow. You think of Lacertus almost perfectly, am I right?
And pain at the compression of the over the proximal edge border of the Lacertus. That's the triad.
Okay, so
Exactly.
that's the triad. So you need to do a provocative maneuver.
Exactly. You need to make a provocative maneuver to your patient. And it's quite, as I said, it's quite impressive. The scratch collapse test, when it becomes negative because you put some cold on it, and the patient, again, after a few seconds, has a scratch collapse test positive, it's quite impressive for them and for you. And you can even try that after the surgery. Well, the scratch collapse test in my hand doesn't become negative straight after the surgery. It can take several weeks or months. But the thing is that it's impressive to make a follow-up based even on the scratch collapse test.
And along with symptoms, paresthesias over the median nerve distribution.
Actually, the paresthesias on the median nerve distribution makes you think more of a double crush syndrome. It can happen in isolated Lacertus fibrosis, but the compression usually is a little bit more distal than just the Lacertus. Those are the cases where you have to think of pronator syndrome and superficialis syndrome. But if you have median nerve paresthesia, I mostly order an EMG just to be sure that there is no associated carpal tunnel. And of course, I also test the abductor pollicis longus and try to compress the the median nerve along with other signs, the Phelan, the Tinel, the McMurphy, all of those signs that we basically and routinely use in the diagnosis of carpal tunnel.
And maybe just to clarify another very commonly used term is the pronator syndrome and the anterior introitious nerve syndrome, right? So these
Yes.
are, these are things that were discussed before the whole concept of Lacertus came out, like in the last 10 years. So we used to talk about the pronator more commonly, am I right?
Well, actually, we used to think that all of the syndromes of median nerve compression at the proximal elbow, proximal forearm and elbow were pronator syndrome. And as I said, I stated and I cited the article of Tang and a few other articles, I think by the team of Ring were also involved in, and Susan McKinnon also were involved in that kind of distinguishing the pronator syndrome from the superficialis syndrome. And to be sure that we use the right terminology, PMNE was also used as a vast global term for proximal median nerve entrapment syndrome. But I think that we have to be really careful about, like I said, in the clinical examination, to be very thorough about where the compression is. In the superficialis pronator syndrome, you also have weakness in the superficialis muscles. You have as I said, compression is painful more distally. Elizabeth, I think in her publication, I don't remember if it was the one of 2013 or 2023, she had few pronator syndrome. I think of all of her patients, two or three of them had, after Lacertus release, needed a revision surgery for pronator superficialis syndrome. But it's like 1 or 2% of 200
Yeah,
patients.
I think Elizabeth's paper mentions around 275 cases, and she
Yeah,
had 6 cases of prolonged.
exactly.
Okay. We also joined by Loy. Loy Al Khatib is an orthopedic sports surgeon based in Dubai. Loy, welcome to the show. Any questions to Mahdi, please?
Sure. Thanks, guys. Good evening. First, thanks a lot, Mahdi, for giving us this really good talk about Lacertus syndrome. You know that carpal tunnel syndrome or release after carpal tunnel syndrome failure rate reaches up to 14-15%. And one of the most common causes of this failure rate or persistent symptoms is lack of proper clinical examination. Again, proper clinical examination. When you guys said about how to diagnose or to differentiate between, so should be all about differentiate between carpal tunnel syndrome and Lacertus syndrome. Is it proximal median compression nerve or is it distal compression? So this comes. You can differentiate only by proper clinical examination, because if you depend on only in NCS AMG, will not give you the accurate answer, because there's the compression proximally is really mild compression. The compression is compressing the perineural plexus of the nerve. There will be no axonal damage that will be reflected on the nerve conduction study. Anyhow, but we're going back to the examination. These examination, three things or three movements should be against resistance. That means when you ask the patient to resist or to flex his or her wrist, you should tell them just flex it and stay there, and you go try to extend it. In that way, you can elicit any deficiency or any weakness in the flexor carpi radialis or flexor FDP, flexor digitorum profundus, and other flexors. That if there's any weakness and there's point tenderness over the lacertus, over the proximal median nerve, then you find, okay, stop, this is not a pure carpal tunnel, or this is not carpal tunnel syndrome, because we know I did carpal tunnel syndrome or release, and still patient in complaint. So I go back, and this is really awful when you need to go back and operate on him again, because he's, oh, sorry, I missed the location of the nerve compression. I see these guys most often after they do after they work out at the fitness studios. They are trying to do workout for the forearm, so we get a pronator hypertrophy. Pronator hypertrophy cause some nerve compression or some symptoms. And what I usually advise, just physiotherapy. First, I always try with the physiotherapy, stretching exercises, for the forearm group muscles. And if there's no improvement, I proceed with diagnostic injection. Mahdi was talking about diagnostic injection, which I really find important. If this is really not a pure carpal tunnel syndrome, you can proceed with a diagnostic injection. And maybe Mahdi can tell us about the really landmark. Is it the same landmark as for the incision for the Lacertus release or not? And maybe this is again this is a dynamic syndrome. So it means that if you do a static nerve conduction study, you will not be able to detect any abnormality. But dynamic, if there's any rule for MRI to do before when you suspect such a syndrome, what do you think, Mahdi? First, diagnostic injection before proceeding to any surgery, and what is the landmarks that you use for this injection, and what's your target? And second question is about MRI. Is there any rule of MRI would you prefer for this type of syndromes?
So as I said, it has been described really lately for the injection. I started to make those injections when no paper was published. Obviously, we already talked about it with friends, and we all talked about our different results involved in Lacertus surgery. But the thing is, as I said, in my hand, it's not really effective in like high compression and really thick Lacertus fibrosis, those that you can palpate through the skin on your patient. You really palpate a cord that's transversal. Usually, I try to make my injection, as I said, where the pain is, which is the proximal border of the Lacertus. So I use actually the triad with the triangle technique, and I try to be a little bit more proximal than where my index finger is. I try to be between 1 and 2 centimeters proximal to that, because the length of the Lacertus in the MRI study I cited is not that actually long. It's less than 2 centimeters. Usually it's 0.9 centimeters width in mean, although there is a big variation between patients and according to the length of their forearm or their length in general. You can base yourself on that. So I try to be really at the entrance of the part that's under the
Yeah.
Lacertus for my injection. I always do it with ultrasound, and I try to be the closest I can to the median nerve. And for that, you need to use, first of all, a good anesthesia, because you're going through the muscle mass. So you really have to be patient and like Donald's teach dust when doing Wadent, really going little by little and millimeter by millimeter and injecting progressively and slowly. And in the meanwhile, it's more sensitive in my hands than the carpal tunnel injection. Carpal tunnel injection, as soon as you release the anesthetic, people don't complain. I mean, they obviously feel the first pinch, and depending on how good you are with that, they feel more or less 0, 1, or 2, 3, and how afraid they are of the needle. And the thing is that with the Lacertus, it's very easy to start pinching the skin, and it's very easy if you really go slowly, but it's less forgiving if you're in a haste. So if you really want to go fast, that's where you're going to hurt your patient. But if you really go slowly, actually the skin is a little bit less innervated, I think, or the innervation termination are a little bit more wide, which allows you to be less painful than a carpal tunnel injection. And as for your question on MRI, truth is that I almost never order MRI for patient unless I have a really, really great doubt about the clinic itself. Scratch collapse test is negative, and when I order an MRI, it's not to make a diagnosis of Lacertus. It's mostly to make a differential diagnosis, because if you really have an ART for the superficialis pronator syndrome, or if you already had surgery for the Lacertus, you can look for another diagnosis, or maybe for adhesions with the nerve or with the pronator muscle. So that's when the MRI becomes interesting in my practice. I don't use it on a daily basis, and far from that.
Definitely, I agree. The most beautiful thing about doing wallet surgery for these guys is that you notice the improvement immediately. So once you do it, once you release the fibrosis there, Lacertus, and you ask the patient to do to flex the wrist, and you examine him, you see the difference directly, that the power is regained again. There's maybe the most difficult question for me to answer these patients in when to go back to sports, when I can go back playing darts, when I can go back playing the paddle tennis, or what's your answer for these guys?
Well, as for all of the other surgery, I think that every patient is unique. Like you said, we test the strength before releasing and just after releasing systematically, and it's more impressive in some patients than others. The same goes with the rehabilitation. I don't prescribe physiotherapy, just the scar massage and like the local massage to avoid adhesions between the skin and the underneath layers. But as for activity, I allow them to go back to everyday and daily activity almost immediately. Since it's a violent anesthesia, they don't have like limb paralysis. So I ask them to use their limb normally in everyday life. And after that, I use pain guided recovery, like we've been talking about a lot lately with Donald Lalonde, and I was doing that for years. I think that everyone is different. Your sensation to pain is different. Your resistance to pain is different. The idea you have of your surgery is also different from one patient to another. So you really have to adapt to your patient. That's why I always make an appointment with my patient in the week after the surgery or 2 weeks after the surgery, just to have an idea of how they're coping with the initial part of the initial post-procedure time. And that's when I adapt my recovery plan. Basically, most of the patient can do whatever they want after 2 weeks when the wound is healed. And I ask them to go progressively and not to start competition at the gym with the friends from the gym at the second week. And I see them again at 1 month and a half, And if everything is okay at that time, I allow them to do whatever they want. It's always guided by your patient. It happens to me once or twice that at 1 month and a half, I'm not very happy with the results of the patient, and that at the ultrasound, because again, ultrasound is your best friend as an orthopedic surgeon, the ultrasound shows some adhesions, and I know that's going to be painful for my patients. So I ask them to work a bit more on the massage with, that's when I may also prescribe some physiotherapy so that they have a physiotherapist that show them strengthening exercise, and especially like you said, relaxation, muscle relaxation exercise and stretching exercise. That's the most important, I think. But I don't give them systematically. It's only when the patient needs it. Sometimes it can be at second week.
Exactly. So as patient-oriented rehab protocol, there's no proper, or there's no one recipe that fits all patients. This is patient-oriented and differs from one person to other. I think that's it, Hitesh. Thanks a lot, Mahdi, again. This is the third time for you here. It's our
Thank you,
pleasure
Mahdi.
to host you again.
Thank you, Mahdi, for this wonderful presentation. That's all the questions that we have for this session, and we really look for more in future. Thank you
Thank
so
you again
much.
for the invitation, and best of luck for all.
Thank you. Bye-bye. Thank you.